Welcome to episode 35 of the Cancer Pod. Join us as we talk about chemotherapy-induced peripheral neuropathy from a naturopathic perspective, and from the perspective of a naturopathic doctor who has chemotherapy-induced peripheral neuropathy. This is one you're not going to want to miss.
I'm Dr. Tina Kaiser, and as Leah likes to say, I'm the sciencey one.
And I'm Dr. Leah Sherman, and I'm the Cancer Insider.
And we're two naturopathic doctors who practice integrative cancer care.
But we're not your doctors.
This is for education, entertainment, and informational purposes only.
Do not apply any of this information without first speaking to your doctor.
The views and opinions expressed on this podcast by the hosts and their guests are solely their own.
Welcome to the Cancer Pod. Hey, Tina.
Hi, Leah.
So we're back.
Here we are again.
Not like, oh, we're just back with a new episode. We're back with the same episode that we just recorded.
Yeah, because the first one, mincing no words, really sucked.
Oh my God, we were so boring.
If we were having a conversation, like at a restaurant over dinner, and we sounded like we did in our first take on this neuropathy, I would have left because we were really, really boring.
Yeah, it was, I don't know what was going on, but chemotherapy-induced peripheral neuropathy is such a huge subject, and it's so important, and I know people want to know more about it. And yeah, they would have just shut us off. They'd be like, no, I'll live with it. I will just live with the neuropathy. This podcast is more painful than my neuropathy.
Absolutely. Okay, and the irony is, I have written on this topic since 2010. Like, I have lectured on it. I've written on it. You know, I know it inside out, up and down from an academic and like a clinical perspective. And I still couldn't pull out anything interesting to say.
Hey, and I've lived with it since 2014.
Maybe it was just a bad day altogether.
It was a bad day.
Okay, so let's do this. Let's just start, Leah Sherman, with you. We're going to start with you. One of tens of thousands of people out there who still have some peripheral neuropathy post-chemotherapy. So I want to ask you, on a day-to-day basis, what is it like to experience this?
So some days it's okay, and then some days it really acts up. So what I initially experienced and what I experience now is way different. My initial experience was the day I woke up after getting my paclitaxel treatment / reaction. I had burning on my palms and on my feet. I had these shooting, radiating, migrating pains in my legs. I mean, it was just crazy because I had handled the first part of my chemo, the AC. I'd handled it so well that everyone assumed, oh, you're going to fly through the Taxol. Well, Taxol hit me like a Mack truck, and I just feel like everything kind of went down from there. I mean, I switched to Abraxane, and all of those side effects continued. I had the sensation of my fingers had been crushed in car doors. Those migrating pains that I mentioned, I mean, those were just incapacitating that I had to take an extra day off following chemo from work because I couldn't walk. There was no way I could drive. It got pretty bad. And acupuncture is what saved me. I guess we'll go more into like what helps, but I'm just going to put that out there in case we forget to mention it, which I don't know why, because it is my favorite thing to recommend. But now what I experience, I guess for like a couple of years following the end of my chemo, like I couldn't wear high heels or really like too tight of a shoe. I had this thing where my feet were kind of numb, but if you stubbed your toe or stepped on something, it was like this crazy magnified pain. Like the pain was like insane. I think of it like as like a Lego. Like you step on a Lego and without neuropathy and you're like, that hurts a lot more than you'd think a small little plastic cube would hurt. It was like that magnified. Oh, and I also had the numbness around my mouth, which was so bizarre. And finally, I guess I just was far enough away that it started to really be where I didn't notice it all the time. And then every once in a while it flares up.
Mm-hmm.
So it's like the tingling, the numbness, a feeling of my feet are kind of slightly swollen, but they don't really look swollen.
Yeah. Now, I'm just going to say it here now because often we're offering people things that will prevent these side effects. We think in retrospect at this point that some of this was exacerbated by the constipation that you experienced.
You and I have talked about this like quite a bit, where I thought I was doing myself a favor by plugging myself up because I didn't want diarrhea because I had to drive 30 minutes each way, to work, and work. And yeah, I'm wondering if just by keeping all of that inside of me
Mm-hmm.
for like 5 days
Mm-hmm.
didn't contribute to the worsening, because I did everything naturopathic
Yes.
to reduce my risk of neuropathy, which we're going to talk about too, of all of the potential things that work with patients, but it didn't work with me. So,
But we think that we at least theorize at this point that that's probably the case because the constipation can lead to having a higher level of the actual chemotherapeutic circulating because you're not releasing it in your stool at the proper rate or at the expected rate. So you might actually get a bigger dose than you otherwise would get, which could make the neuropathy or any side effects more severe. So that's what our premise is at this point, because you did do everything one could do as a naturopath,
right.
other than stay regular.
Right. Yeah.
Yeah.
So, okay. So peripheral neuropathy, like what is it and why does it happen? So it's nerve damage that happens as an effect of getting chemotherapy,
Mm-hmm.
and depending on the chemo, it affects different parts of the nervous system, or the peripheral nervous system, I should say.
Yeah. So as far as chemotherapy induced peripheral neuropathy, the drugs themselves, and there's a whole list of drugs that can cause this as a side effect, they affect the nervous system in different places. So some might be at the very ends of your fingertips, right there at what are called the C fibers. There could be damage. There could be damage right in the spine where there's what's called a synapse, where one nerve talks to the next nerve that goes up to your brain. And that would be other drugs. So we can put that on our website. And a nice picture, a diagram to tell people where it's happening. In the end, it feels similar, though. It doesn't matter where it happened. Like, your description is what people experience, whether it's the numbness, the tingling, or downright pain, if it's severe enough. Peripheral neuropathy presents to the patient similarly, no matter how the mechanism happens.
But the same drug can present differently to different people.
Yes.
Which is just wild. And what I found really fascinating was I found myself repeating the way things were described to me by patients. I naturally just said, "Oh yeah, my fingertips feel like they were crushed in, car doors." And then I was like, "Whoa, I've had patients say that to me before. This is what they felt." And I remember at the time hearing them say that, thinking, "Oh, that's so unusual. I've never heard anyone else say that."
Mm-hmm.
So it is interesting to hear how people describe, because it can be very individual. It does tend to be bilateral.
Mm-hmm.
So it'll be both hands, both feet, that kind of thing. And it often starts at the very tips of your fingers and then starts to come up your hands, sometimes to the, past the wrists. And the same thing with your feet, right? It starts with the toes and it starts to kind of climb up in that sort of that stocking glove distribution.
Yeah. So this is very specific. So we're just talking about chemotherapy-induced peripheral neuropathy today. And it's similar with some other drugs. There are other drugs out there that can cause this.
Right. And it can be exacerbated if certain medications are being taken, or if there are certain conditions that people came into chemotherapy with.
Yes, predisposing them. Mm-hmm.
So another part of it is, it's not only the sensation of numbness, tingling, pain, burning, but there can be altered sense in like temperature. People can experience just like an overall like weakness in their legs and arms. You can have problems with balance. And then, as I mentioned, there can be other organ systems that are affected, like your gastrointestinal system. Sometimes it feels like food just isn't moving along the digestive tract. And then there can be urinary issues too.
Yeah. Yeah. I mean, you really do start to appreciate the integration of the nervous system with every function in your body. So every muscle has to be innervated. Every sensory nerve plays a part. So it's kind of interesting to think about how much can be affected by this one side effect. And for every person, it's different. This goes back to, if someone has a side effect, report it. If something is unusual, report it. If your lips are numb, report it. If you are hearing something in your ears, report it. Like, just jot it down between visits and report every symptom, because it may seem odd, unusual, or kind of freaky even, but it might make sense to the doctor. It may add up.
Right, because you mentioned hearing. So yeah, you could have hearing changes and vision changes too. Really, any part of you that's innervated potentially can be affected by the chemotherapy. So let's do a quick little break, and then we'll come back. We'll talk about conditions that predispose people to CIPN. And we'll do a quick list of some of the more known drugs that affect the nerve. So let's just kind of quickly run through some of the drugs, or at least the categories of drugs that can cause chemotherapy-induced peripheral neuropathy. So the big ones that people hear about are the platinums, the taxanes, and the vinca alkaloids.
Mm-hmm.
There are others, which we'll put in our show notes, but these are like the big three.
Yep.
Probably because they're used most frequently. Taxanes and platinums are often used together, so that's like a double whammy.
Yeah, so I think it is frequency of use. And they do have different mechanisms. So when someone is getting a platinum and a taxane, those two classes of drugs, which is often used in something like ovarian cancer, several other cancers as well, but ovarian comes to mind. They're two different mechanisms of neurotoxicity. So you are getting a true double whammy, like you're getting it from a couple different angles. So nearly everyone has some level of neuropathy if they get that combination, and we stave it off and then do our best to repair the nerves after treatment. And a lot of our work from an integrative medicine perspective takes place afterwards so that we stay out of the way of the actual treatment.
Right, because the concern is that if you are taking something during treatment, is it interacting with the treatment itself?
Yes. And then the assumption is if you lower a side effect, then yeah, you can assume it's interacting with the treatment unless you've been proven otherwise, or unless the risk benefit weighs out so that you should use it. So we're going to talk about that next, which natural supplements and integrative medicine is used alongside some of these agents. But everything is a risk benefit. You weigh the risk and the benefit of everything. And that's true of the conventional side and the natural side. So it's no different. So when we get to it, we'll talk about why we think some things are worth the risk.
And sometimes, like we've mentioned, like patients come into treatment either taking a medication or having some sort of predisposing, condition. Like diabetes is a huge one, because diabetes already puts a person at risk. If they have uncontrolled blood sugar, they're at a higher risk without chemotherapy of having neuropathy. There are some nutritional deficiencies. The big one I think about is when someone has B12 deficiency. But then at the same time, you don't want to willy-nilly take a B12 supplement to prevent neuropathy, because that might not be the issue or the concern,
right? Unless
you have pernicious anemia.
Right. So this goes back to making sure you have enough of every nutrient, which is repletion, which is very different than depletion. So if you're depleted in B12, then you have a deficiency, then that can present as a neuropathy all by itself. But if you're repleted, which is a new word for a lot of people, repletion just means you have enough of it. You're not taking mega doses. You're just making sure you have an adequate amount is repletion. So that's what we try to make sure everyone has.
Something else that can deplete B12 is if somebody has a history of alcohol abuse. I mean, it can deplete several B vitamins. Other medications like metformin, having thyroid conditions can lead to neuropathy. Something physical, like if somebody has thoracic outlet syndrome or carpal tunnel, it's not that the chemotherapy is going to necessarily worsen that. It's just, it's like a confounding factor.
Right. They have what would be more of a compression of the nerve, like in carpal tunnel. And then if there's a toxicity to the nerve on top of it, it's an additive thing. So you're adding two different types of neuropathy together, which could result in symptoms sooner.
Yeah. And then age itself. So, and that may be a part of just having a different metabolism of the drug or just nutrient deficiencies that can happen as people get older.
Yeah, yeah. And you mentioned the B12, and then there's the B1 of alcoholism, and also B6. So, yeah, as people get older, they just don't absorb them as well sometimes.
Yeah. So what can be done to reduce the risk? If you look up in ASCO, they're going to say nothing.
Pretty much nothing. In the ASCO stands for the American Society of Clinical Oncology. And we should put a little posting on our website of their recommendations and maybe a little caption as to why we don't go by them in this scenario, because basically they say don't do anything.
Right.
No exercise even.
Oh, interesting. Well, but do they say things like don't smoke, limit alcohol, control blood sugar levels, keep your bowels moving? Do they say any of that? Because those are things that are recommended in other sites. I don't mean like
Yes.
websites. I mean like other resources.
Yes, I think that they are clear about just keeping up regular bowel movements, but they actually say they're against a lot of the things that very selectively can be helpful. So, for example, I'll give you an example. Vitamin E. They're moderately against anyone taking vitamin E. The level or strength of the evidence they call intermediate, and the benefits for vitamin E are low and the harms low. So they assess the risk benefit as low on both sides. So don't bother. So they're going to say don't take it. Now, vitamin E doesn't work across the board. It's true. I mean, that's what the headlines of the actual published papers say. Vitamin E does not work for chemotherapy-induced peripheral neuropathy. But if you go through the data, you can see vitamin E does work for one particular drug. Vitamin E has good evidence against certain drugs, and that's the platinum drugs, the cisplatin and carboplatin in particular. So that's the only time it may be worth taking. It may not be worth taking for other chemos. It's the strongest evidence is by far with those drugs. So my point with ASCO is they make a blanket statement on the vitamin E for all chemos on here in this paper that we're going to put up. But it's hard to do any blanket statement for any natural agent and say peripheral neuropathy because there's different causes. And so you have to match
right. And they're different drugs. So, and like with what you're saying with the platinums and vitamin E, isn't that because the platinums may cause a vitamin E deficiency?
Yeah. So interestingly, yeah, we don't know if this is because it's actually having some kind of nice amelioration of the symptoms, or is it just because the platinums may be causing a vitamin E deficiency and we're preventing that from happening by having someone take vitamin E? That's unclear right now, but peripheral neuropathy induced by vitamin E deficiency looks a lot like peripheral neuropathy from a platinum drug.
And I should say, like, that's where a lot of both the conventional ways of addressing chemotherapy-induced peripheral neuropathy as well as the integrative/naturopathic approaches, they're kind of taking it from other causes of neuropathy. So it's like, well, this drug is prescribed for diabetic neuropathy, and so let's try it for chemotherapy-induced. And we kind of do the same thing with how we're addressing neuropathy with natural agents. It's that same sort of like, if it's not due to a blatant deficiency, then it's, well, we use this substance for diabetic neuropathy, so let's see how it works with chemo.
Yes, that's often been done. Mm-hmm. And so there is evidence. So just let's be clear, there are published papers on this topic. This is not just kind of connecting the dots. There are actually publications saying when people took vitamin E during the time that they received, a cisplatin or carboplatin, they had less neuropathy. So I want to be super clear about this because we're not connecting dots ourselves. We're just going by what's actually been published from clinical literature.
Yeah.
And I want to say one last thing because this is often a question. ASCO has a different bar of evidence that they will use, and it might be a higher bar. I will admit that all day long. We often will put this through is there a reason not to take the vitamin E that may be helpful for someone to prevent peripheral neuropathy? If there's no reasons to not take it and it may be helpful, then it seems worth it because it's very inexpensive and there's no risk to it that has ever been seen or proven or that we know of.
Not the dosages that we would recommend. I mean, if you do super high doses of vitamin E, you run into a greater risk of something happening, which we will get into in the next part. But
well, and I want to say, because we're going against ASCO, which is, this is a giant group of experts who know medical oncology unlike anyone else, because they are the go-to group. And for us to talk and say we don't really take their guidelines at face value, we do something a little different. I think we need to justify that up the wazoo. So the reason I'm saying this is they also don't recommend, on their recommendation list, they do not recommend gabapentin either. So it's not just natural agents.
Right. It's medications, and they don't recommend any of the SSRIs other than Cymbalta, duloxetine. So like that's the only one that is recommended. Don't try anything else.
Yeah. So the level of recommendation here is so tight. The standard is so tight that they don't even recommend what is commonly used. Standard of practice is to use the SSRIs or to use the gabapentin.
Yeah, or cryotherapy, right? Cryotherapy, you go into cancer centers and patients are icing their hands and their feet, whether they're wearing gloves and booties or they're just, got the ice in a plastic bag.
Yeah.
I mean, patients are doing this. Cancer centers are offering these services to people, and it's not a guideline through ASCO.
No. So the ASCO recommendations are so tight that it's practically nothing is recommended. And that doesn't seem reasonable when you're given the risk benefit of lifetime neuropathy and someone who's getting, a treatment where it's likely to cause neuropathy. I mean, it doesn't make sense to me.
And, and it's a curative treatment, right? I mean, it's like the goal, it's curative intent, and you're left with this lifelong, symptom. So, okay, let's go back to cryotherapy. So cryotherapy has been studied with taxanes.
Wait, I don't know if people know what cryotherapy is.
Oh, ice. Cryotherapy is ice. Ice, baby. But you have to be careful with cryotherapy because you can't leave the ice on for too long because you don't want to cause frostbite.
Mm-hmm.
So, yes, the use of ice during an infusion to reduce the risk of peripheral neuropathy has been looked at with paclitaxel.
Mm-hmm. I think the most, yeah.
The most, yeah. So the one that it is contraindicated with would be oxaliplatin.
With good reason.
Which is it's a chemotherapy that is used in like colon cancer and pancreatic cancer. And it can cause a side effect, which is a neuropathy of just this cold sensitivity.
Yeah, you basically get zapped by anything cold. It's like a zap, like a really strong zap when you grab something that's cold, even out of the refrigerator sometimes.
Right. And you're warned about drinking anything cold because your throat can spasm and it can feel like you're choking, which you're not, but it's just that cold reaction. And it usually lasts for about 3 days after the infusion, often starting during the infusion. I mean, I had patients who, before they even got their infusion of oxaliplatin, were eating ice cream because they're like, I can't have ice cream for 3 days. And so they're sitting in the infusion room eating something cold, like challenging,
That's
I'm
funny.
going to beat this. I'm going to get my ice cream in before. Yeah, no, I haven't had more than one patient do that. Or drinking their cold drink because they don't like room temperature water or whatever. So I did find a study from a couple of years ago looking at the use of ice therapy or cryotherapy during oxaliplatin to see if it reduced that very sensitivity. And it sounded like torture.
Mm-hmm.
I think so much that a third of the patients dropped out of the study.
I'm surprised it was only a third. Yeah.
Yeah.
Well, and that seems like it shouldn't even have really passed any ethical review board, because the idea of giving someone who's getting oxaliplatin, putting their extremities on ice of any kind, seems like that's asking for trouble. That doesn't seem right.
Yeah, that doesn't seem right at all. Something else that I have found, I guess more recently in the news, in the medical circles, is exercise. Exercise is being promoted as a way to reduce your risk.
Mm-hmm. That makes sense. I mean, just in the idea of good circulation in any tissue that is healing, because while your nerves are being assaulted by the chemotherapy, they are also always trying to heal. Like any tissue in your body, after you get damaged, your body automatically goes into trying to heal the tissue that's been damaged. So on that note, it seems like anything that increases circulation should increase the healing potential.
So that seems like a very kind of low risk thing to try to reduce neuropathy. I mean, it's low risk as long as you're not having issues with balance, which can happen with neuropathy,
Yeah.
And again, this is going to be kind of in the recommendations section of this podcast, but I am a huge proponent of people seeing occupational therapy and physical therapy, especially when it comes to peripheral neuropathy, because they can offer tips. Occupational therapy helps with those kind of day-to-day situations. Physical therapy can provide exercises and make sure that you're being safe. Maybe you do need a walker. I know I encountered that with my mom, where there was a certain amount of pride with using a walker. But when she realized that, she had such weakness from going through treatment and the neuropathy, the walker could substitute as a little seat. You put on the brakes, you sit down.
Yep.
She used it to carry her purse. She loved it to carry her purse.
I've seen people put coffee cups on them, like put a coffee cup holder on it.
Oh, sure. And I think we originally got her a cane thinking that would help. And when she saw the physical therapist, they're like, no. Cane is not appropriate for her. This is what she needs. So it's just kind of, and what kind of cane do you get if you get a cane? So just taking that off of your plate and going directly to a physical therapist as well as an occupational therapist to help. I guess we don't have to address this in the next section because we're addressing it now. But I do think that is really, really important. And there are things that they can provide that isn't something you can do at home, like neurostimulation, getting a TENS unit, which is the rebuilder. What's the other thing that the scrambler is another name for one of these kind of devices that stimulate your nerves. So
I was just going to say each of those is an electrical stimulation that either interferes with pain from the nerve or helps regenerate the nerve is the idea of it.
Right.
Just in case people didn't know what neurostimulation was.
Oh, yeah. No, but I think it is good to bring that up now just because the way I don't want to leave out acupuncture, I don't want to leave out physical and occupational therapy.
Yeah, I totally agree.
We've already mentioned like the conventional drugs, right? The anticonvulsants like gabapentin and the one SSRI, duloxetine or Cymbalta. There are some topical drugs that have been looked at, which I used when I was down in Arizona, as we had a compounding pharmacy. And so that was really nice to be able to use some of these drugs, which can cause side effects like drowsiness, like gabapentin, using it topically mixed with other drugs like baclofen. Ketamine was another topical drug that would get compounded. I remember when I first started working down there and wasn't quite familiar with these compounded formulas, there was a very popular formula including lidocaine, which I eagerly prescribed for a patient who was experiencing not only like neuropathic pain, but also had numbness. And he slathered this lidocaine compounded cream on his feet, and his feet they became more numb.
Yeah.
Which was not really the result that we were looking for. So, not all of these topicals work for everybody.
Well, and it's all relative, right? So if he had painful neuropathy, he would have welcomed the numbness.
Right. But pain and numbness.
Yeah. So if you were numbing the pain, that would be awesome. But numbing your feet is probably not ideal because then.
Right. I mean, that formula was probably better for somebody who had a post-surgical kind of neuropathic pain.
Right.
And you would apply it to, your chest or your arm or wherever the surgery had been. But yeah, applying it to your feet was, that wasn't one of my finest moments. But using things like menthol, that's really nice because menthol kind of tricks your nerves into not recognizing the pain.
Yes. Just like Icy Hot.
Yeah.
Most people are familiar with Bengay or Icy Hot or some of these over-the-counter, they also use it for muscle relaxants in that case, but that also interferes with, pain signals.
Yeah. That's something that I would have patients try at home, whether it was just using Vicks Vapor Rub, which a lot of people tend to have at home. You can try applying that to your hands or your feet, or Icy Hot. It's not something that is going to change or reverse
Right.
the neuropathy. It's just going to help manage the symptom, especially at night, because that's when you feel it really the most, is when you're kind of laying still, or at least for myself and many patients, is, you're laying in bed and it just becomes even more noticeable.
A lot of things get worse at night. So any symptoms you have can be worse at night. That could be itching on the skin. It could be aches and pains. It could be neuropathy in this case. But your cortisol is so low in the night, you don't have that natural anti-inflammatory effect that cortisol gives you during the daytime.
Oh, yeah. Did we even mention that those pro-inflammatory cytokines may also be, that's what's being implicated as one of the causes of this sort of neurotoxicity? I don't even think we covered that.
Part of neuropathy, part of it is due to continuing inflammation. So this is systemic inflammation. This is also considered neuroinflammation. So just as a global effect, if you're inflamed systemically, if you are in an inflamed state, meaning there's more of these cytokines in circulation, wherever you are feeling inflammatory reactions are going to act up. That could be osteoarthritis. It could be neuropathy. If you have neuropathy from chemo in the past, it could be a skin condition like eczema. So systemic inflammation will present itself to you as symptoms wherever your vulnerability is. In this case, it could be post-chemotherapy neuropathy.
And a really interesting thing that can happen is someone can, I don't want to say sail through, but somebody can go through their courses of treatment totally fine, no neuropathy. And you mentioned that you have seen where later the patient says, I have neuropathy now. What happened?
It's puzzled me my entire career. They'll end like Taxol and a platinum drug. You're like, this person's probably going to get neuropathy. They go through, they finish treatment with no neuropathy, and then 3 months, 4 months later, they're like, I'm having neuropathy. And you called it what again?
Well, coasting was a term that I had encountered.
Yeah, like late onset neuropathy. It's really unusual, and I don't have any great explanation for it, to be honest. I mean, I've definitely seen it in patients. It's unusual, but it can happen, and I've always been a little bit baffled by it. Yeah.
Well, I like mentioning the unusual because there's probably at least one person out there going, oh my gosh, that's me.
Yeah,
and
you're
so
not alone.
I like people to know that, you're not alone, that there is somebody out there. It may not be common, but it can happen.
Mm-hmm.
So anything else we want to cover in this section, or should we do another little break?
I say we do a break and then we come back and talk about some natural agents and which ones are appropriate when.
All right, we are back, and we're going to cover some of the integrative therapies that are used to reduce the risk as well as to treat chemotherapy-induced peripheral neuropathy. So I think what might be easier is if we kind of talk about one of these therapies and we can cover the indications as well as the contraindications.
Yeah, that sounds good. Yeah.
So that we don't have to come back. We'll just cover it all.
And as I mentioned, we like to be really specific. Like you take this natural agent with this particular chemotherapy or this other natural agent and don't bother with others. So this is not a shotgun approach. This is a very specific approach using the evidence that we have to date.
Following treatment, there is a little bit more wiggle room with some things.
I'll give you that.
But yeah, I mean, there are certain agents that we would never use once treatment has ended, but then there's some that are kind of interchangeable.
Yes, and repletion is always okay, right? So just making sure you're never low. And this is diet. When you talk about repletion, I'm usually saying diet, unless there's an issue with absorption of a nutrient.
Yeah, and we haven't actually said that yet, which is interesting because usually when we start talking about repletion, we're like, food first. So this is the first time we're saying it in this episode, food first, repletion.
Yes, repletion. Make sure you're not exacerbating your neuropathy by being deficient in B vitamins like B1, B6, B12. So make sure you're eating well, eating whole foods and real foods. I'm going to say real food over whole food even, because now there's all this fake food out there, that claims to be healthy, but it's not healthy. It's just fake. It's processed food that's organic. It's not healthy.
That's like a whole new episode.
I know. I'm just saying that because when we say eat well, we don't qualify that with what we mean. So real food and whole food.
Right.
Let's start with one that's misused even in our own circles.
Oh my gosh. I know which one you're talking about. Glutamine.
Yeah, glutamine.
Yeah, it's glutamine. Yeah, glutamine. L-glutamine has been studied, and there were mixed results in the studies. Some were favorable, some did not show any benefit. But it was very specific as to which chemotherapies it was used with, and depending on the chemotherapy, it depended on how long it was being used in terms of like days and whatnot.
Right. So the first one out of the gates was back in 1999, 2000 was 30 grams. That's 30.0 grams per day of L-glutamine for 4 days, beginning 24 hours after taking a taxane drug. So that's paclitaxel and docetaxel, Taxotere or Taxol, if you want to know the name brands at least at that time. Those were the only two available. The study looked at taking that really high dose. 30 grams is a powder. That's a ridiculous number of capsules. So yeah, generally it's a powder, and it starts 24 hours after your infusion stops, and you continue it for 4 days straight, and then you stop taking it. That's how it was used in the study. And it showed that it lessened aches and pains, peripheral neuropathy, a lot of the things that you described earlier in this episode, those things that you experienced, it lessens a lot of those neuropathy side effects.
And we're going to actually devote an entire episode to glutamine, but just quickly, L-glutamine it's an amino acid, and it is the most abundant found in the body.
Mm-hmm.
All of our cells use it. We're going to talk more about it in a specific episode, a special episode. What are you looking at?
I have a poster of all the amino acids on my wall, and I was just looking at the structure of glutamine.
I thought you were looking out the window. I was like, what, she got like a squirrel out there?
It is next to my window. That's funny that you say that. No.
Okay. So L-glutamine is very specifically used with the taxanes and the platinums.
Yes, in high dose.
In high dose. The times that it is not used would be in patients with pancreatic cancer and after treatment is over.
In high dose.
In high dose.
So I'm gonna explain the qualification of in high dose thing, because they did the 30 grams. If you only do a small amount, you do 500 milligrams, 1,000 milligrams, you take a capsule and you're doing it for your GI tract, because we often give glutamine for the lining of the entire GI tract for its health, because it's a preferred fuel source for those cells. So your small intestine cells, especially, and your upper small intestines, they like to use glutamine as their fuel source, right? They'll take in the glutamine and they'll break it down and they'll use it for their own health. So we use it to heal the gut a lot. And in those lower doses, I think it's perfectly safe because it doesn't get past those cells. Those cells take it up and it never sees the bloodstream in that case, because the intestinal cells are using it avidly. So the large doses is used in order to bump the bloodstream up, because you saturate the small intestinal cells. They take in all they need, and then there's extra, so that flows into the bloodstream. So when we say don't take it afterwards, we mean large doses.
The large doses, the 15 grams twice a day or the 10 grams 3 times a day. Yeah.
It's not going to help.
Right. There's no evidence at all. I don't even know if it has been looked at, but it's not something that somebody should take.
There's not even a reason in theory that ultra high doses of L-glutamine post chemotherapy is going to have an effect on your nerves. Like, there's nothing that I can think of. And the reason that we are downright against doing it is glutamine is taken up by tumors avidly as well. So it's only second to glucose as far as a fuel source that cancers in general like to use. So we are really cautious about that. Like, if a cancer cell likes it, then we tend not to want to give it, right? And so the reason it's okay for those 4 days is because the taxane drug is having its effect. So it's okay during that time if the cancer cells are dividing. That's how the taxane works. It needs those cells to be dividing. So if you are giving glutamine while the taxane is in your system, if those cancer cells at all are enjoying that glutamine for their own use, it's okay, because the taxane's taking them out at the same time.
We had a medical oncologist who worked with a lot of patients with GI cancers, and he was the one who brought up not using glutamine with patients with pancreatic cancer because of that reason.
Okay.
because of the preferential
Yeah.
diet of the cancer cells being glucose and glutamine. So that's why I don't use it with patients, even though they're getting a platinum. So we've already covered B vitamins. I mean, you've got B1, B6, folic acid deficiency, and then B12.
Mm-hmm.
Again, those aren't something necessarily given willy-nilly. I've said willy-nilly twice in this episode.
Yeah, what's with the willy-nilly today?
I don't know. My vocabulary is very limited today. So do you recommend B vitamins?
I have.
I know I used to.
Yeah, I was going to say I have pulled back a little bit over the last 20 years, especially. I mean, we used to give B vitamins. Wait a second. Wait for it. Willy-nilly.
Willy-nilly. I feel like that isn't that like the name of a penguin cartoon?
That's Chili Willy.
That's Chili Willy.
Oh God. No, we did.
No, but we did. Yeah. I mean, like in my training and then, my early years out of training, yeah, there was a product. It was a folate-free B complex that we would give to patients. I took it myself.
Well, and here's the reason. B vitamins are a cofactor. If you want an enzyme in the body to work more efficiently or have more function, you can increase the cofactor, in this case of B vitamin. Now, in the days of orthomolecular medicine, we used a lot of high dose things, including the B vitamins, to push these enzyme reactions. And now we have a little more respect for the fact that, cancer is also just another system in the body using the same enzymes for its own purposes, right? So do we always want to increase particular enzyme systems when the cancer cells themselves are using it? Maybe not. I mean, this is why we're more cautious. We just know more now. So we pull back on that whole B vitamins do no harm idea. That's not completely true. We haven't proven that they do no harm at high dose when people have cancer present.
I will admit that one of the reasons I stopped recommending it, I mean, in addition to what you said, because more information is coming out about high doses of certain B vitamins may drive certain cancers, is just the fact that they smell so incredibly bad. I stored mine in the freezer. I think first I stored it like in the closet with my other supplements. And then I'd open my closet and I was like, oh my gosh, this is so bad. And so then I put it in the fridge and then I moved them to the freezer and I would open the freezer and it was just like that smell, that B vitamin smell. When you're going through treatment, you don't want to smell something like that. And so it was really hard to take. And then because I wasn't digesting my food appropriately or, adequately, I should say, I would just burp it all day long because I was getting a steroid. And so my digestive system was wacky. I mean, I cut back on how many supplements I recommend to patients.
Those are people patients.
People patients. No, I cut back on my recommendations dramatically after going through treatment because it really is hard. I mean, I went in all guns a-blazing, taking all of these supplements, everything possible, and I was like, this is gross. This is just too much. Like things just sat in my stomach. I didn't want to take them. And so I started to pare back because I realized I'm like recommending these things to people and they should be eating food.
Right. So there was that whole idea of people taking their supplements but not eating, and that was always a bad thing. Yeah, well, I want to tell you that with the smell of this stuff makes me nostalgic. So, I mean, it's a bummer that you have a reaction probably to this day from B vitamin smell.
Oh, it makes me nostalgic too, but not in like a happy nostalgia way. More in a, oh my gosh.
Yeah.
Does it remind you of like Flintstones?
No, although those were delicious. But no, it reminds me of, I did work study in the pharmacology department, and they used a lot of Drosophila flies on the floor I worked on. And apparently, the stuff Drosophila flies eat is a lot of yeast nutrient, and that smells like B vitamin, basically. So whenever I smell it, I think of the pharmacology days and my college days. And so it's like the polar opposite of your feeling. I'm like, oh, that smells good to me.
And I'm like, no, I don't want that.
Yeah. Yeah.
But yeah, there are several reasons to not recommend B vitamins, and there are a couple reasons to possibly recommend them. Um, Acetyl L-carnitine, that was one that also was used quite frequently
Hmm.
during treatment until the study came out that said that patients who were getting a taxane and taking acetyl L-carnitine actually had worse neuropathy.
Yeah. And I pulled that one up just before we started talking today, and it was published in late 2017, 2018, depending whether you look at electronic or paper version. Um, But yeah, acetyl L-carnitine is one of those things that after treatment is over, I recommend across the board almost, like for chemotherapy induced peripheral neuropathy and repair of the actual nerves. It can interfere with some of the signaling if it's painful or numbness. It can also, at least in animal studies, it looks like it could help with some of the repair of the actual nerve. Um, but it has to be taken in really high doses. And so I'll tell you exactly how I do it because I want to spare people. If it's not working for them, I don't want them to keep buying it on faith. So I'll start people at a really big dose, like 3,000 milligrams a day. Often I'll do it in a powder, although the powder tastes disgusting. So,
Oh, I like it.
oh, you
It's
do?
so
Oh, God. See, we're the opposite.
no. See, it smells gross to me. It smells like, well, it doesn't smell gross. It smells like vinegar, but it's so tart.
It makes me make a face just thinking about it. So
I
gross.
like that tartness. That's funny.
Oh,
Okay.
okay. In any case, I start with 3,000 milligrams and then have them take that for 1 month. And if they see absolutely no effects, then I say it's probably not going to be something that you're going to want to use. At 3,000 milligrams after 1 month, if they have some effect, meaning the neuropathy seems to them to be improved, I'll have them go down to 2,000 and see if they can maintain some benefit on 2,000. And I usually stop it at 1,500. But the dose is always between 1,000 and 3,000. I just start high because I'm like, well, why would you do it the other direction? I have never had anyone have any effects. There's no nausea. There's no side effects. It's like, you may as well know in 1 month whether this is worth your time and effort or not.
Do you do it, and you do it in divided doses?
Usually twice a day. I try to get them to do 3 times a day, but compliance goes down with every dose you give someone in a day. So
Oh yeah, but people aren't taking the 3,000 at once.
no, no. And ideally away from other amino acids. But again, there's the ideal and then there's the practical. So it depends what people are able to do.
so on an empty stomach because food has amino acids.
It will compete. Yeah, it will compete with amino acids. So you do have to be a little bit careful there. But, I also am not, I try not to go into all those nuances. It's like, if something's going to work, let's just do it. Because
Right.
on a practical note, you're going to take this for how many years? You're going to be taking for 2-4 years afterwards while your nerves are healing. And, it's not easy to do everything perfectly. So there's always the ideal recommendation or prescription. And then there's the realistic one, right? More practical one.
Right. People just trying to get the supplement in as opposed to, we have those patients who are so regimented and they're great because they're like, this is when I eat and then this is when I take my supplement and they're
Yeah.
so organized.
So some people are suited for it. Yeah, some people they have no problem doing the ideal, and other people are like, if I can't do the ideal, I won't do it at all. And so you have to
Right.
each patient is a little different. You just compliance is ultimately what you want. Nothing works if you don't comply with the prescription, drug or otherwise.
So kind of like riding on the heels of acetyl L-carnitine is alpha lipoic acid. And what I think is very interesting is that I have seen integrative providers who aren't NDs recommending alpha lipoic acid during chemotherapy.
Oh,
And yeah, and I was just reading on, there are like these groups for people who practice naturopathic oncology, and everyone kind of gets together and talks about different cases or whatever. Somebody had mentioned that there are oncologists where they're practicing who are recommending alpha lipoic acid during chemotherapy too. And we've talked about this before. I mean, we talked about this in the first time we recorded this episode. But that is something I would not recommend because alpha lipoic acid is such a strong antioxidant.
yeah. Yeah, it's one of those I avoid during treatment because it certainly increases the production of glutathione and other antioxidant enzyme systems within cells, and that includes cancer cells. And so the idea of giving something that is going to be an internal, intracellular antioxidant, those are so powerful, and glutathione itself, and so many chemotherapy drugs work on that pathway to give something that is going to undo what the chemotherapy is supposed to be doing, which is oxidize that cell. It's so counter to anything. Like, that is completely what we should not be doing. So I'm a huge, like, no alpha lipoic acid. And on the same note, for the same reason, no N-acetylcysteine.
So I found a study that was published in 2022 that looked at alpha lipoic acid and paclitaxel-induced neuropathy, as well as doxorubicin cardiotoxicity, which, having heart problems after getting adriamycin/doxorubicin is a big issue too. And I don't recall in the article them talking about like looking at it 5 years out, 10 years out, 20 years out. So while it might help in the moment, are they not considering, is there an increased risk of recurrence in these patients? I don't think that it's been studied long enough.
Right.
But they were using 600 milligrams once a day.
Just once a day? Because I know that former studies had done 600 milligrams 3 times a day.
The study was, I think the information was collected between 2019 and 2020, and it was published in 2022. But it was an oral dose of 600 milligrams once a day.
And it did prevent neuropathy?
Yeah, there was benefit seen.
Yeah, this goes back to what's going to happen over 5, 10, and 20 years for those folks. We don't know. So the reason, so I want to explain this to someone. So I mentioned earlier, we're going to look at risk benefit. And it does take a lot of knowledge of all of these natural agents and the biochemistry of what's going on and how they're working in order to even weigh the risk benefit. Because if you just go by the studies, it's not always giving you the full story. So this looks like, it gave people some benefit. It lowered their neuropathy, but at least theoretically, it may do so at the cost of interfering with the efficacy of the treatment, because lipoic acid is so reliably a stimulator of the production of glutathione and other antioxidant enzyme systems. And just to be clear, in a lab, when we take, say, cisplatin, carboplatin, in a lab, we use NAC, and we probably could do it with lipoic acid too, but it's customary to use something that increases glutathione to prove that that's how it's killing the cells. So because glutathione in particular is such a potent way of nullifying the effects of chemotherapy within a cell, anything that increases it is kind of a no-go in my mind until that is proven to be okay. Because it's more than a theoretical risk. I feel like we've already proven in animals and in dishes that you can undo chemotherapy with these agents. So why would we go and give it to a human when, if you extrapolate, it's likely to undo the chemotherapy's therapeutic effects? The risk benefit doesn't weigh out for me in my mind. That doesn't make sense.
Right. I mean, until it's proven to be absolutely safe, it just doesn't seem to be something that's worth the risk.
Right. And that might be true of other things like vitamin E, but vitamin E doesn't work on the same mechanism. So we talked about vitamin E with a cisplatin earlier, and that too was proven to lower neuropathy induced by cisplatin and carboplatin drugs. But vitamin E mechanistically does not increase glutathione in the cell. It's not an antioxidant within the cell in the same potency as our own antioxidant enzyme systems. It is an antioxidant on its own, vitamin E, but it's not going to have a strong effect like lipoic acid has on a cell. So it has to do with these nuances of understanding antioxidants and understanding the molecular biology on a level that is confusing, because literally you'd have to know molecular biology to weigh all the pros and cons, all the risks and benefits.
So bringing back to vitamin E, the big caution that I think of is anybody who has issues regarding bleeding. So taking, but we said it's also not super high doses. I know in order to interfere with clotting, vitamin E has to be at a pretty high dose. Mm-hmm. But for people who are on anticoagulant medications, warfarin is the big one that I always think of, which I guess it's not so popular anymore because of the other anticoagulants.
Yeah, if someone's on those things like Eliquis, you mean?
Yeah.
Those, yeah.
So something else that people are cautioned about in terms of bleeding, increasing a bleeding risk, but it may be helpful, reducing the risk or even addressing afterwards the peripheral neuropathy are omega-3 fatty acids, because there's EPA and DHA are the ones that we think of. And so it's that DHA that is supportive to the nerves.
Yeah, there was that one small trial that used fish oil in people getting taxane drugs too. It was very small, so it's not really something to hang your hat on, but it did show some benefit in one trial alongside the taxane. And you know, when it comes to fish oil, I'm not a mega doser. I'm like, what would you get if you ate fish? 1,000, 1,500 milligrams total EPA DHA is what you would get when you eat fish. And you do have to just make sure that you're also eating well alongside your fish oil to make sure that it doesn't get oxidized. So, yeah.
Yeah, and so that's something that can be used afterwards too. And it may be better tolerated after treatment, because if there is any nausea, it again is something that people don't tolerate. I like a certain brand that has enteric coated capsules, and so they kind of stay together. But the big advice I used to give to my patients is don't chase it with something warm. So if they're having it in the morning, if they're like, oh, I forgot to take my fish oil, and they take it in the morning, don't chase it with a cup of coffee, because that will break the capsule apart. I probably talked about that in the omega-3 episode. I find myself repeating myself, but you may not have listened to the omega-3 episode, so go out there and check it out.
Yeah, and since I forget everything that you said, intentionally.
Intentionally or unintentionally?
No, intentionally. Because then we got to keep our conversations fresh. So how am I going to keep our conversations fresh if I don't forget everything you've already said?
I know. It's like we're going to turn into some old married couple where we tell the same stories over and over again.
Yeah.
All right. And so I mentioned it at the beginning. It is something that I do recommend to patients as they're going through treatment as well as afterwards, and that's acupuncture. There are Chinese medicine herbs like TCM, traditional Chinese medicine herbs and herbal formulas. I know that when patients have seen acupuncturists outside of the cancer center setting, that their acupuncture providers will recommend for them. And I know there's some studies showing that there may or may not be benefit. I steer them away from them. I don't know enough about Chinese medicine to say, yes, there is no potential for interaction. So maybe after.
And, yeah, I have so much respect for all of the Eastern medicine and traditional medicines that I feel like people who practice that medicine practice it in the traditional sense of the culture, which means they have to assess that person to make it an individual treatment, right? So even neuropathy is not going to present the same across the board for everybody. So it's a constitutional thing.
Oh, absolutely. Yeah. And I think that, there are definitely integrative providers who are also acupuncturists who work in oncology settings, and that probably would have more familiarity with the chemotherapies, the treatments that are being used. And so, they may know more of the evidence out there in terms of if there's potential for interaction. But yes, it's not like this one formula is for everybody, because of the fact that they are taking into account so many of the individual features of a side effect.
Yeah. Western medicine in general is based on symptom and then treatment rather than looking at the entire person, making an assessment and the nuances of the presentation, like how it presents, when is it worse, when is it better, what does it feel like, is it connected to any digestive symptoms? Like the entire person is taken into account in traditional medicine. Many traditional medicines, whether it's Ayurvedic or Chinese medicine or Tibetan medicine or, go on and on around the planet, the whole person is taken into account. So I often will just refer to people who are practicing traditional medicine to do that whole thing instead of giving someone because some people come to me and like, do you think this is going to work? And it's a traditional Chinese medicine formulation of a bunch of Chinese medicine herbs that I don't have any knowledge of how to apply anymore. We learned it in school briefly, but that never stuck. So I just tell them, if that's what you're interested in, here's a few names to go see.
I would make sure that they definitely have, a strong oncology background. So there are other therapies that have been looked at that I haven't really had a ton of experience with. The low-level light therapy, cold laser, which I think of for more pain.
Me too. Yes.
Pain, can be part of neuropathy. So, that might be helpful there. Biofeedback is something that you always see being mentioned. And then I know there are studies looking at cannabinoids, CBD products,
Yes.
and neuropathy. I have not seen a lot of benefit with that actual, the numbness and tingling. I've heard patients say it can help them with pain.
That makes sense. Yeah.
But the pins and needles kind of part of it, I haven't seen a huge amount of success, but I haven't seen a huge amount of people who are using it. I've probably had more people use topicals.
Yes.
Because there is always a potential for anything herbal to interfere with medications. And so
on that note, in a future podcast, we're going to go into depth on the cannabinoids, on medical marijuana. So we're going to have a whole discussion.
Yeah, but we're going to have experts.
Yeah, not
we're
us.
We're just be asking questions.
Right. With people who know this stuff much, much more in depth and detail than we know.
Oh, absolutely. Yeah. So yeah, we can see. And again, everybody is different on how they react to cannabinoids. And so maybe there are some people who it benefits and others it doesn't.
I've had CBD be very beneficial for pain relief in patients taking it internally. So pain specifically, right. Or some people for just relaxing for sleep. And I think even when it's helping them with sleep, it's because it's helping with some of their aches and pains. So I've had quite a few people take CBDs. Some of them take THC and CBD together for various reasons. I mean, anti-anxiety or, that stuff. So I know the other plant medicines better than I know marijuana.
Yeah, and I'm even more cautious when there's THC involved because that, I believe, has more potential to interact with medications.
Oh, we didn't mention that we really like to recommend is the good old yoga toes.
Oh my gosh, I love yoga toes.
Yeah.
So yoga toes, and then I've also seen those happy feet socks because when you Google yoga toes, for whatever reason, then you start getting all these ads on social media for happy feet.
Mm-hmm.
And so there are these like silicone looking kind of brass knuckles for your feet that separate your toes and they increase circulation. I think they're for like people with like plantar fasciitis, but it feels really, really good.
Yeah.
I love those yoga toes. Yeah. We'll put a link for those too.
Yeah. So basically just pulls them apart a little bit. Puts a little space between the toes and increases circulation as far as I know.
And I think it helps with balance too. I mean, I know personally it helps me with balance, when I have like a loss of sensation in certain parts of my feet. But yeah, it gives you that stability because like in yoga, spreading your toes as you're standing on the mat is like really beneficial. And so the yoga toes do that. And you're just kind of like chilling. I always tell people, grab your tea, grab your book, the remote control, grab a blanket, sit down, prop up your feet, put on the yoga toes. I think you start off using them for like no more than 10 minutes. Have your phone next to you because you don't need to get a phone call and run across the room because it will hurt really badly. I didn't have my water next to me and I was like, I could totally get up and get my water wearing these things. No, don't do that. It's painful.
So you could have the socks for that though. The socks would be okay. But not the yoga toes.
I don't know if you're spreading your feet apart.
Isn't the socks just have extra material between the toes though, like a glove?
Yeah, I need to order a pair. I'm going to order a pair of those socks. Okay. I recommended them the other day, but I'm going to try them myself because I shouldn't recommend things unless I try them. So yeah, I'm going to get myself a pair of those.
All right. Well,
happy feet. Report
back on that.
I will put a post about them. I will post it on the Instagram. So speaking of Instagram, before we talk about where people can find us, which is such a weird thing to say because people are listening to us, so they apparently found us here. But we do have a song.
Oh, yeah? All right. What's the song?
The song is Shock Me by Kiss.
Nice.
You can tell that I'm like a classic rock kind of a person. So yeah I love Kiss. And Shock Me is our song, which you can find on Spotify on our unofficial theme song playlist. And then there's also a link in our show notes and a video on our website.
Yeah, so that's awesome. Thank you for finding that once again. That the Spotify playlist came up randomly in my RV one day. I think I told you. Out of nowhere, all of a sudden, I turn on the engine and the thing starts playing I call it your because I have nothing to do with our choices, but our Spotify playlist. But what's funny is
I didn't cancer pods.
Yeah, I didn't notice it, but my partner was like, I think that's your playlist. I was like, is it? It was a long ride too, so I got to listen to the whole thing. So we rocked out a little bit.
Oh yeah, and I think it's a pretty diverse.
Oh, it's awesome! It's a great
collection.
Playlist. Yeah.
So, Yeah, Spotify is one of the places you can listen to us. Maybe that's where you're listening to us now. You can find us wherever podcasts are streamed. And where that is a great place for you to leave a review.
Yes, it's always helpful to give a little review, a little shout out. Give us 5 stars, please. And if you want to give us less than 5 stars, then just email us and have a little chat with us, because we're going to probably share some of the feedback that we have gotten thus far in some later episodes.
Oh, yeah, we're starting to get letters.
Yeah. Fan mail.
Fan mail.
Oh, and the other place you can help support the show is Buy a Coffee. And Buy a Coffee is just a place where you can buy us a cup of coffee, donate $5 to our cause here, keep us on air, and keep us going.
Yeah, help us pay for all of those little things like web hosting and whatnot, that kind of all the behind the scenes stuff.
Our huge production staff that's behind us on this.
Yes, all of the hamsters spinning the wheels. They're very well paid hamsters.
Yeah, and they need to eat a lot because they're constantly spinning.
Yeah, they're working hard. All right, on that note, I'm Dr. Leah Sherman.
And I'm Dr. Tina Kaiser.
And this is the Cancer Pod.
Until next time.
Thanks for listening to the Cancer Pod. Remember to subscribe, review, and rate us wherever you get your podcasts. Follow us on social media for updates. And as always, this is not medical advice. These are our opinions. Talk to your doctor before changing anything related to your treatment plan. The Cancer Pod is hosted by me, Dr. Leah Sherman, and by Dr. Tina Kaiser. Music is by Kevin MacLeod. See you next time.
This was long.